All right. Well, thanks so much, everyone, for joining. We're so thrilled to be with you this evening to be discussing the who, when, why of salivary testing. I'm Brian. I'm one of the co-founders here at Bristle, and just want to give a short introduction to our speaker, Heather Kenny. So, Heather's been practicing dental hygiene since 2005. She's practiced in areas of dentistry, including general private practice, DSOs, periodontology, as well as biological and holistic based practices. Heather currently enjoys practicing as a biological oral health coach, where she assists Bristle clients and private clients in creating oral health routines based on salivary testing results. As an HIAOMT certified hygienist, she's gained knowledge on the oral microbiome through the use of phase contrast microscopy, salivary testing, along with studying the many aspects of disease processes into the mouth, including nutrition, airway, and gut health. There's also the support coach for Bristle and in training practices who are interested in utilizing and implementing Bristle salivary testing and enjoys dental professionals become leaders in dentistry through true prevention. I'll just add, Heather's probably looked at more Bristle oral microbiome test results than anyone on the planet by this point. So excited for the presentation. I'll be sharing some information in chat about how you can learn more about Bristle testing, but without further ado, Heather, take it away.
Awesome. So I just want to say thank you so much for joining us today. And then whoever did sign up and wanted to listen in later, thank you for signing up and putting us on your calendar for a later date. So thank you. I appreciate your interest in what Bristol has to offer. And we were talking earlier and how this should be the standard of care when it comes to dentistry. And I'm hoping that we just kind of revolutionize dentistry for the future for prevention purposes. So today we're going to cover the who, when, why of salivary testing. I am going to introduce a little bit of the salivary testing and what we do and kind of comparing it to some other tests on the market for those who are maybe not utilizing Bristol at this point and kind of just setting us apart, and comparing the different ones on the market and why I think Bristol is amazing. So let's just cover a little bit of what we're going to cover today. So we will discuss who is a good candidate for salivary testing, and I'm going to demonstrate what process of salivary testing can look like in your practice. So we've been a salivary testing company that's been direct to consumer. We're moving that towards practitioners and helping practitioners utilize the test in practice. So we're going to show you what that process might look like in your practice. You'll learn when the salivary testing can be optimal when evaluating patient risk. We'll highlight where the testing can help drive treatment acceptance and aid you in the treatment planning process. And we'll reveal why salivary testing is a better prevention than the use of probes and x-rays. So I'm a huge proponent that if we don't know what's there, really the old school way is probing and x-rays where we're actually looking for disease existence, not really preventing disease of the oral cavity. So the biome matters. So as Brian said, I started my journey with phase contrast microscopy. It was a huge part of learning in the holistic side of dentistry and really blew my mind and started my evolution into this biome craziness, which I think is amazing. So the bacterial, viral, fungal overgrowth drives disease processes. We've known that. I've graduated from 2005. We learned in our periodontal classes that dental disease starts with pathology, whether it's strep mutans or it's, Fusobacterium nucleatum and P. gingivalis. And so much of dentistry has, been more of the tooth scraping and then drilling and that sort of thing, and really not focused on the microbial side of things. I love sharing slides. I do this so much with my clients just to show them how the bacteria lives and thrives in the mouth. We have biofilm that is biofilm based, the sticky biofilms like Fusobacterium and Enterobacterium, and then there's the T. denticola and Porphyromonas that are more swimming and free floating in nature. So understanding how these bacteria live and thrive in the body and move about is really key when it comes to helping to treat our patients and what products we might put in play or what home care is needed in order to mitigate those types of things. So I love the biome, and understanding those species and how it affects the body is super duper important. So uh, I'm just gonna move to the who. So who should be testing? Oftentimes we need to kind of consider, who we might be testing. In the ideal world of Heather Kenny and Bristle, I think everybody would be testing, but we definitely should be testing our perio patients, our caries patients, those tricky cases. And that's generally what most offices are doing currently. But the Bristle test can help you customize periodontal therapies and really check in with the biome to understand whether you're making sustainable long-term shifts for your patients. This is a really nice quote and statement from one of the doctors who utilizes the test. And this is an amazing perio chart of one of my clients who came to me. I presented his case in the last webinar where, he went from 12 millimeter pockets, and in combination of working in the dental practice that he was seeing, having his LANAP treatments, and then going through the bristle testing process and home care routines, we, significantly decreased his periodontal pocketing along with, his diet and other things that he was incorporating as well. But we can just make some significant changes for our patients, and long-term health outcomes are much better when we understand the microbial imbalances and where those are. So candidates for testing. Oral condition. So any of your perio involved patients, I highly recommend making sure that you're testing, whether that's like, where are we at now and how do we move forward? If you have a perio patient and you're doing scaling and root planing, testing, prior to and then after is super valuable to understand whether your treatment is actually successful or not, and really understanding where they're at in their progression of periodontal disease in the first place. High caries risk patients. Caries is caused by a whole lot of different situations. So understanding which pathogens might be the core cause, or maybe it's not pathogens, maybe it's airway issues. But our high caries patients, you should be testing to understand the root cause of what's causing those caries issues. If you were on the call prior, we were just talking about oral surgeons who place implants and how important it is to make sure that the oral environment is stable before placing implants. Implants fail. For such a long time, we were told that implants, once you get them in, it's like the end all be all, and this is the fix for all problems. Well, after working in perio offices, I just, I my heart was broken so many times by patients who were losing implants because they were poor candidates and they weren't stable. And it's a lot of investment for the patient, and it's a lot of time for the doctors. If we have those microbial profiles for patients, we're going to know whether they're going to be a good candidate, and we can improve their ability to keep that implant safe. And then there's just troubleshooting. I have a really cool case study that I'm going to present a little bit later with just sores in the mouth and trying to figure out what is causing some discomfort and sores for your patients as well, that could have a microbial component to it as well. So those are the oral parts, and that's what we think about in dentistry. But for such a long time, we've also been preaching the oral systemic connection. So I want you to think outside the box as well. Like, we need to start thinking about our patients who have systemic conditions, our cardiovascular patients. I was just sharing prior to that one of our offices is now paired with the cardio department in her area, and they're doing salivary testing and clearance with the bacterial components to clear them for their cardio surgeries, which is really brilliant. Cognitive disorders. We know that the bacteria like P. gingivalis and T. denticola and others are involved with the development of Alzheimer's disease. And then history of GI issues, and I'll kind of talk a little bit about some GI connections and oral health in one of the cases today as well. But our pregnant patients, we know that they're at higher risk for pregnancy loss or adverse outcomes. So anyone who's pregnant would be a great candidate to do a salivary test on, and just make sure that their oral microbiome is sound and safe for that baby. And then respiratory infections, diabetes. So I highly encourage thinking outside the box from just oral disease, but also those systemic connections as well, so that we can be truly preventative for our patients. And I don't know about you, but there's so many of our dental patients who have those cardiovascular issues. They have, family history of Alzheimer's disease, diabetes issues, and diabetes patients, everyone should be tested. That diabetic component and the inflammatory response and perio is so tied together that it's like detrimental if you don't have those components and understand. Sometimes those perio patients with diabetes can have a low profile of bacteria, but their inflammatory response from that diabetes is a real problem if our insulin levels are off. So, and vice versa. So those diabetic patients are a fantastic person to be making sure that we're checking in. And then, of course, prevention. I think prevention is the key when it comes to dentistry. I've been saying for such a long time, dentistry is so reactive. So when we talk about, testing our current oral conditions, it's still a little bit more reactive. We know there's, disease there, but we could test preventively and actually catch these bacterial overgrowths way before it starts to show clinically in the mouth. So if you truly want to practice preventative dentistry, I highly encourage the idea of just doing all of your patients and really working towards prevention in general. Um, the current trends right now, like I said, are mostly using the test for patients with active decay or periodontal disease. A lot of times it's troubleshooting your tough cases, those who you've done some scaling and replaning on maybe several times and you're just not getting resolve of those inflammatory responses. We have some offices using it for new patient evaluations, which is fantastic. We have some functional dentists and doctors who are also evaluating gut health. Gut health plays a huge role in oral and systemic health as well. And we know that bacteria is tied to the gut health. Functional dentists also can evaluate some of those systemic connections as well. Baseline testing, that's more that prevention as well. I think every office you have to start with a baseline to understand where your patient is and where your treatment's going. So that's where the baseline comes in. And then prevention, I just mentioned, just catching everything way before we start to see disease presence taking place. So for those of you who aren't familiar with the Bristol test, we use shotgun metagenomics. It's a little bit different than a lot of the tests that are on the market currently. So shotgun metagenomics looks at the bacteria, fungi, viruses, and parasites, and we can get all the way down to the species and strain. And we're looking at the whole genome, and it's a good functional profile. So there was a new study that came out and talked about Fusobacterium nucleatum and certain strains that are more problematic with patients with colorectal cancer. Shotgun metagenomics has that quality to it. There are some tests on the market that are using 16S. Those are more targeted sequenced, and they look at the bacteria. They can get to the genus and species. And then most of the testing on the market is qPCR. So we all know a lot about qPCR because of COVID testing, but we can do qPCR testing for specific strands. And that's where HR5 and those types of things are using to just get targeted, parameters of bacteria. And then, of course, the conventional microbiology part, that's my slides for my microscope, which I started microscope slides and moved to salivary testing because I knew stuff was there, but I didn't quite know what it was. So I really wanted to know what I was looking at with the slides. So like I said, Bristol test, we test for 800 different microbes, fungi, and viruses that could be present in the mouth. Generally, what I see is usually between 65 and 150, usually different types of microbes as a scale, but we have up to 800 that we can find. And there's some fun ones that I do Google and research a little bit that can be there that shouldn't necessarily be there always. Oral DNA, I like to show the testing too. So I think Bristol is really affordable in the aspect of what we're looking at. So we're giving you the complete picture of the oral microbiome with the Bristol test. Oral DNA, you can start with, just their perio, then you can add on your caries, and then you can add on, HPV and then other things into their tests, and that gets an additional fee per. That's also qPCR testing. We have direct diagnostics, which is the HR5. They're just looking at 5 bacteria, and it's usually your red complex perio pathogens. And then there's a new one on the market, Simply Perio, that's right around $100. They're looking at 12 species. It's your orange and red complex perio pathogens. There are 2 caries pathogens, Streptococcus sequens and Strep mutans that they're looking at. And then they also do Candida albicans on theirs as well. Once again, a qPCR. So that just kind of explains how we stand a little bit different than some of the testing on the market. Why? So why would we be testing? So looking at the whole picture is why. So what does bristle test show? We are going to give you the beneficial bacteria. We really focus on more of the prevention and the environment when it comes to testing. It's not about killing everything. It's about making sure that we're catering and growing a healthy environment in the mouth. I never really have a zero, tolerance for any of the bacteria. My goal is to get it, low enough where we're not having any type of symptoms in the mouth and getting everything in a happy green space. So beneficial. Gum inflammation, we give a gum inflammation score, a tooth decay score, a halitosis score, and a gut impact score. We give you the nitric oxide score. So nitric oxide reduces nitrates, reduced to nitric oxide. That starts with healthy, beneficial bacteria in the mouth. Super important. Nitric oxide is tied to blood pressure. It's tied to insulin resistance issues, and it's tied to your immune system. So we really want to make sure what we're doing in the mouth, we are catering to the beneficial bacteria and not wiping everything out. And diversity is another score that we give because there's a window of healthy amount of bacteria. We don't want to kill 99% of germs in the mouth. We want to make sure that we're keeping a good relationship within the oral environment. So we'll give you the orange and red complex information and your caries in a brief overview. And then we also have some really fun raw results that you can really kind of dig into as well. So we'll be able to give you all of the species that's found in that specific person's oral microbiome and dig into what's really there if you're having trouble. And that I'll kind of go over why that's beneficial in one of our case studies that I'm going to present today. So, and we really need to know what we're dealing with. Salivary testing gives you the opportunity to understand what's present and how each bacteria may live and which treatment and probiotics might be beneficial and, how it might live and tolerate oxygen. And then also, if it's living in a biofilm or if it's free floating in nature. So in our test scores, you can see whether it's gram negative or gram positive. That's how the cell wall might be. Gram negative bacteria are a little bit harder to get rid of than gram positive bacteria. I have the shapes in there when using the microscope. That was one of my insights to them. I said, can you please put the shapes in? That helps me explain to the patient, is it a sticky biofilm-based bacteria that might disclose and I can help you understand how to brush better? Or is it a swimming bacteria like T. denticola where it's a spirochete and it's swimming in the pocket or the crevices of the tongue or in the tonsillar area and you need to use a water flosser for those types of bacteria? So we give you some insights that way. We tell you whether it's anaerobic or aerobic. So bacteria that are anaerobic don't like oxygen. So using oxygen against those bacteria can be super beneficial. And then we are huge components of using probiotics as well. So probiotics are like companion plants. They're bacteria that we can put in the mouth and they help to correct the environment as well. So in each of the bacterial scores, you'll know whether that bacteria is susceptible as a bactericidin to some of the probiotics that may be recommended in the oral care plans. And we should understand the beneficial bacteria. So like I said, nitric oxide We get a nitric oxide score by looking at the bacteria that have the capability of reducing nitrate into nitric oxide. That's an important part of our bodily function. Nitric oxide is used for a number of different things within the body, and that starts in the mouth and having a high nitrate reducing bacteria load and making sure we're feeding them is super important. So things like nitric oxide, supplement like Super Beets or Neo 40, or I love the sugar-free Super Beets as a supplement to make sure that we're feeding those good bacteria and really catering those bacteria and getting them high so that we have that nitric oxide reduction. All right, when all right. So this is kind of the meat and bones of, one of the things that we wanted to cover today. So when is the best time for you to be doing the salivary testing in your practice? So we have a couple different models that we're doing right now. So we have a few people that we're testing out where we're doing the test before. So we're reaching out to that office's patients and we're getting the test in the hands of the patients and trying to get them to test before they even come into the office so the test is ready to go. And we're seeing some really exciting responses for that test process. You could also do that as well if you have a new patient or someone who's coming in. You could have them come in, pick up a test, and then test prior to, so that you have that baseline test prior to them coming into the office so that you're prepared with a treatment plan based on the microbial load. If you are a doctor or your doctor is doing the new patient exams, that's the perfect time to start your salivary test for your new patient and do it right first thing with the patient before. This gives you the ability to then shift your hygiene appointment to something that would involve dealing with the bacterial load and not just how they're presenting clinically. And I'll kind of get into that a little bit later because there are some patients that will be high pathogen, low clinical presentation. So you can capture those that way. So in the new patient exam, if the doctor is doing that prior to hygiene, that's really nice to get that bacterial test done right away. And then, of course, hygiene, first thing in a hygiene appointment, before doing anything, you can do your test. Sometimes that's a little bit tricky to get compliance of your patient. So perhaps you're thinking about doing the test and then you sit the patient back and you confirm that they might have gingivitis or perio or cavities. Maybe you're going to send a test home with them and have them do that test at least 3 weeks out from that hygiene appointment. So you want to make sure that you're spacing that test out. You don't want to test your clinical abilities. You want to make sure that you're testing after the biome has actually settled to actually check in with that. But the best thing to do would be test at that hygiene appointment. That would then require some sort of consult or follow-up appointment where you could do some sort of telehealth or a consultation. So that track kind of pushes you into some sort of consult that way. Sending it home with the patient. So if you have, say you're doing a scaling and root planing, your last appointment, you're like at your 6 to 8 week visit where we're going to evaluate how the treatment went. At 4 weeks, I want you to do your salivary test. So at that 6 to 8 week appointment, we can then evaluate the success of our scaling and root planing. That's where you could send it home with your patient. I always say, if you have a box, or I don't have my little salivary test, but if you have the next visit on here, you could write next visit and then test date. You want to do that about 3 to 4 weeks prior to the next visit appointment. So you get your test results prior to, and then you'll know the success of your scaling and root planing. You could do that for your perio patient. So that's another way that you could approach testing within your office. And then, of course, you want to make sure that you're treatment planning according to the bacterial load and how that patient is clinically presenting. And there's a few things that you want to consider when it comes to doing chairside testing. So you don't want to have your patient eating or drinking for at least 30 minutes prior to them coming in. And then no over-the-counter oral products for at least 30 minutes. You don't want them taking an oral probiotic prior to. I have some tests that come in, and sometimes the caries score will be high, and lactobacillus plantar will be still in the mouth, and it will drive the caries score. And I'm like, well, there's one or two reasons. Either you took the test a little too close to that score, or you might have some incipient cavities and that's sitting in. It doesn't necessarily cause a cavity, but it'll stick in some of those sticky demineralized areas. So you don't want them using any type of strong antimicrobials for at least 24 hours, like chlorhexidine or a stannous fluoride product. Like I said, at least 2-3 weeks out from any type of hygiene appointment. You want to make sure that they haven't had their teeth cleaned or any other procedures for at least 2 to 3 weeks. And that just allows the biome to kind of resettle in. Like I said, you don't want to be testing your clinical skills. You want to be testing what the biome is for that patient. And then, of course, they shouldn't be on any type of systemic medications and things like that for at least 6 weeks, just to make sure that we're not. Systemic antibiotics will knock off and throw your tests off significantly. So don't test during any type of antibiotic treatment. This is a good time for, if your front desk person is doing confirmation calls, just to remind the patient, there's no need to brush today. Don't go ahead and use anything. We are thinking about doing a salivary test at your appointment. And this is a reminder, we want you to be ready and don't eat or drink or brush before coming in. Us hygienists don't need you to brush your teeth prior to, like, that's our job. It's not going to be a big deal. Don't eat onions, please. We'll be okay. So the sample collection can be super simple. So it's not super time consuming when it comes to being chairside. It's literally opening up the box. I have a little sample here. So your box is going to come with your mailer bag. It's going to come with a funnel, and you're going to have 2 little vials here. It's 2 because if you cross-contaminate it or you drop it, you have an extra one in your sample. And then you also have a biohazard bag that you have to put it in. So you literally see your patients, any health changes that we need to be aware of, go over health history, take your blood pressure, take your pH if you take a pH, do those types of things. And then say, hey, why don't we grab a sample of your saliva in case we want to send this, out to the lab. So you're going to take the blue cap off. Of course, you're going to be gloved during this process so you're not cross-contaminating. Stick your little funnel in. Have the patient spit into the funnel. And I always had mine fill it up to the top of the vial, but just 1/3, at least 1/3 left. So about 2/3 full. Take it off and cap it, and then give it a little shake. And then you're going to register it by using the barcode that's on your test vial. Pop it in. And you can pop on our website and register your patient and pop this right in your envelope and pop it in the mail. It takes, as long as your patient's able to, salivate well enough. There's some patients who don't have enough saliva and it takes them a little bit longer, but it really is about 5 minutes to get the salivary test chair side. You want to do it first thing before you're probing or doing anything in the mouth so that you're not contaminating the mouth prior to. Now, that being said, I usually took a microscope slide prior to, so my routine was, bring them back, health history. I took a sample of spit for pH testing. I did a microscope slide that introduced me, whoa, we have bacteria there. I need to look a little bit further. Let's do a salivary test. So I did not see a major problem with just touch for, probing areas, but we don't want to be probing the entire mouth and spraying water or anything like that prior to doing the test. Currently, this is kind of our March and April trends right now as far as what our current offices are doing for testing. So In March, about 27.8% of the tests were for new patients, 34% were for existing patients, and then we had testing at 18% for patients who are having caries issues and 19% for our perio patients in March. And the numbers are roughly the same for April as well. So about 40% existing patients, 18% for perio caries patients. But once again, this is, testing for disease processes. I love the new patient screenings as well. So, and then, getting a baseline for your existing patients is really fantastic. So testing for existing periodontal disease, why is that beneficial? So when you have high pathology and high inflammation, that's going to confirm disease presence for you. And it's going to show the bacterial component to the patient and help drive your treatment accept. So once a patient understands that there's a bacterial infection that's causing that inflammatory response, and you can put that bacteria, in red and show them that this is the main cause for this bone loss that's happening in your mouth, that can drive the treatment acceptance for you. So the patient that might be sitting the fence on, wow, I just want my cleaning today, that will help you drive that treatment process. And it may help you drive your planning processes and decisions as well. Your moderate pathology, hopefully, again, that's going to just drive that inflammation, whether it's, moderate or high, those patients need to be treated. But then when you have low pathology and still high inflammation, you may want to look at other drivers of inflammation. And this is the other cool thing that you get to see in the test. And I see this with patients all the time with my client calls, where maybe we have low pathology, but we're still having bleeding and, recession and loose teeth. What's causing that? One example, I had a patient, diabetes, her A1C was at 14. Well, we have buckets of inflammation out this way. Today I had someone, she's suffering from long COVID. She's got a ton of inflammatory cytokines out in left field here. Even though her periopathogens she was low or moderate with, she's got a lot of bleeding and she's got 4 and 5 millimeter pockets. So she's getting recession and, perio issues, but it's really because we have a cytokine over response here that's causing that autoimmune disorder with even low pathogens. So it can kind of point you in some other directions as far as what we need to start looking at. Mouth breathing. I talk about mouth breathing and airway issues all the time. Is your patient mouth breathing? Do they have sleep apnea? Hormones are another reason. I have one client who knows I cannot go to my dentist. I have perio issues. And if I go with my period, I'm going to be bleeding like a stuffed pig. She has severe hormone problems with bleeding. So she knows not to go during that time because her bleeding is going to be out of control just because of the hormone issue. So it's going to help you drive your treatment planning processes and perhaps even referrals when you have someone who has a low pathology and then high inflammation. And if they're low and low, that's great. That means you have a stable situation. So that is hopefully your goal. If you have a high, you want to get them to low, right? So that the goal too is we test and retest, and we want to get them to the point where we have low pathology, low inflammation. So if you test and you have someone who has past perio, like if you have a new patient and you have past perio and you test, then they're stable if they're low inflammation and low pathology. So it kind of helps us understand those incoming patients as well. And then decay, super fun as well. So if you have high pathology with high decay, it confirms that you have a disease process. It may reiterate the bacterial component that might be driving that treatment and help drive acceptance to the treatment. And I really want to reiterate too, like oftentimes we miss the antimicrobial aspect of caries prevention. A lot of times fluoride gets thrown at it, or maybe even hydroxyapatite. I know I'm huge into hydroxyapatite too. But those are the remineralizing agents that we need in the mouth, possibly, right? But it's not dealing with the bacterial component that's causing the demineralization in the first place. So understanding the pathology that's present with decay is super important too. So, and it's going to determine if you have someone who might have low pathology with decay, maybe that's going to be a watch for a little while. And you're going to try those remineralizing things and, work on salivary health and diet to see if you can remineralize certain areas. So it might help you gauge where your patient is at risk and whether you're going to be right on decay or watch areas, or you're going to sit back and say, let's try to remineralize. And I do want to point out this. It's not always strep mutans. I brought this test in because I learned with a microscope that Candida albicans is a major, major problem when it comes to gum line cavities and decay for kids. So when we think about caries, all of the research is like strep mutans, strep mutans. I hardly ever see strep mutans. Like it's one of the last pathogens I see in the caries score. Caries is a multi-poly, and these bacteria work together in creating a really nice acidic environment, but different ones play different roles. And Candida, you really want to watch, and you want to treat Candida, and treatment of Candida isn't going to be fluoride or hydroxyapatite. We have to kill the Candida problem. And same thing with the other bacteria as well. So it's going to give you a root cause of what bacteria may have that role in the caries problem. And then you can start treatment planning. Like Candida albicans, it's sensitive to a couple things. Maybe hydrogen peroxide is going to work great. I'm getting really great results with hydrogen peroxide and Candida. I had a specialist, a naturopath, give me a remedy with colloidal silver and aloe. I'm holistic. So, and then I also believe Candida albicans, if it's at 5.8, like in this person, they probably have some significant gut issues. And it's one big long tube, guys. So it starts in the mouth, but your stomach is also infested with Candida albicans. So it's probably a good idea to maybe refer to a functional or naturopath or someone to help deal with gut dysbiosis and Candida overgrowth, because that too has a huge impact on your caries issues as well. So like I said, strep mutans, not always the problem. I brought this slide in because honestly, Prevotella dentacola, I see more often in patients, and they have in between the teeth caries. So I've had a few of my own with Prevotella dentacola being the highest pathogen in the caries factor that's tying to caries issues. And I do think Prevotella can cause some gut issues as well. I've talked to a naturopath who can find it in the feces, and she notices her patients who she's seeing in the fecal samples, Prevotella dentacola, also have cavities. So I do think that there's a gut component with Prevotella, but then I also think it's also a pretty good acid forming bacteria as well that's causing those in between, interproximal decay. So do look for Prevotella dentacola. It's anaerobic. It's not sensitive to oral probiotics. It's anaerobic. So things like chlorine dioxide or hydrogen peroxide or ozone work great against those types of bacteria. So how does this impact your treatment planning? Like I said, it gives you the whole picture. So a simple spit test can tell you maybe this person has an airway issue. Maybe they have a gut dysbiosis problem. Maybe there are systemic issues that we need to deal with. We can identify over 800 microbes, fungi, and viruses, and we can identify the bacterial component that may be contributing. But then maybe low nitric oxide reducing bacteria can also indicate possible airway issues. Nitric oxide reducing bacteria thrive on the back of the tongue. They like oxygen most of the time. The beneficial nitric reducing bacteria are they're aerobic or facultative. Sometimes I see tongue coating bacteria that snuff out our nitric oxide bacteria. So if I have a halitosis score that has a lot of tongue coating bacteria, most of the time my nitric oxide levels are going to be low. So I need that person to be tongue scraping and dealing with the tongue coating bacteria so that I can bring that nitric oxide level up. Saliva health is so important. pH maintenance is super important. All of the bacteria that are problematic in the mouth love a more acidic environment. So the more alkaline we have the mouth, the more beneficial it is for the good bacteria and the nitrate reducing bacteria. The more acidic the mouth, we're going to have more demineralization, and we're also going to have more pathogens that cause inflammation and halitosis and caries. So pH is everything. So our care plans do involve really paying attention to, our pH levels and things like that. Gut health, that gut impact score is super important because gut impact can affect vitamin transport. So for instance, Fusobacterium nucleatum can be contributing to IBS. IBS is tied to vitamin deficiencies like vitamin D and K. D carries calcium. K2 lays it into the structure. So if we have a leaky gut from the bacteria in our mouths, then we're not transporting our minerals properly and we get cavities and bone loss. So that is another, considering factor. So it's going to help you with referral processes, and it's going to help you think outside the box, or it's going to help you identify the bacteria involved so that you can be more specific with your treatment planning. And it's also going to test whether your treatment planning helped or not. We do have quite a bit of guidance within our platform on different ways that the testing may help you clinically as well. So for instance, this is like for traditional tooth decay, depending on the moderate or high level, maybe you're going to watch something, maybe you're going to put them on a 3 or a 4-month recall, doing, fluoride treatments and things like that. So it might, understanding the bacterial components may help you understand how aggressive you need to be with treatment and how frequent they need to be coming into the office. And then we also give you some retest frequency. Like if someone's low, maybe once a year is fine. But if someone's high, you probably want to test until you get them into the green where they're low. And until you get them stable, you're going to be watching and monitoring and treating that patient. And same thing we have for the integrative. So once again, these will be different treatments. Perhaps you're doing ozone, phase contrast microscopy, pre-rinsing, and then increasing your frequencies as well. So we give some guidance when it comes to what the scores are and how they're presenting with decay. And we do the same thing with gum inflammation as well for both traditional and with integrative practices. So including, some of the high scores, and then, what treatments you might want to incorporate as well, along with testing frequency. And like I said, you want to treat, test, and keep doing that until you get them healthy. That should be the protocol. Test, treat, test until they are stable. Let's just talk about preventative testing, because this identifies what category your patient might be in general. So I love the idea of preventative testing. I think this is the true prevention. So everything that I mentioned before, and I'll talk about the model shortly, has been really, even though we're still digging and we're looking, it's still kind of reactionary in nature because we're still testing disease process, right? So preventative testing gives you the ability to test someone even if they don't show the presence of disease. And you're going to find the more you do testing, you're going to have a lot of patients that have high pathology and maybe no oral symptoms at that time. This is going to identify risk for future disease, and it's really the true prevention of oral and systemic disease processes. So it's going to help drive treatment planning decisions as well for those patients because instead of just doing a prophy, maybe you're going to do something different. But, high pathology with oral symptoms, it just confirms your disease presence. Low pathology with oral symptoms, once again, you're going to start looking at those outside factors that might be a contributing factor, and then whether your patient's stable or not. So I think that preventative testing is really amazing. And this is where your biggest impact is going to be. When we talk about testing, let's face it, we are in the business. So we have to talk about a little bit about a return on investment of the testing. So the biggest impact, you may not change your perio patient treatment, right? Like if you're testing for a perio patient, you're basically testing and then you're testing your treatment. And your treatment planning might change because what if your treatment wasn't successful? And here's an example of that. I had a patient that I was doing slides on. I did scaling and root planing, and I did laser treatment and ozone. And my scaling and root planing was I see you once a week for 4 weeks. I clean the entire mouth, guided biofilm therapy, laser treatment, ozone. And we do it again in a week. And I treat the entire mouth as a series. And I build out for one quadrant at a time, spent an hour and a half each time cleaning the entire mouth because it makes sense that we're cleaning the entire mouth when we're treating periodontal disease. It's a bacterial infection. So at his 4 to 6 week visit, I do another slide and I have amoebas and I have spirochetes everywhere. Clinically, he looked better. He had improved, pocketing. So in a traditional office, it would have been like, oh, we got a good result. There's less inflammation. It's better. But microbially, I was like, like, what are we doing? Like, we're worse. We have antamoeba in here. Those eat your white blood cells. We have spirochetes swimming around. I have to switch something up. So this testing does that for you, for your perio patients. So that's where the big impact is when it comes to testing your current disease patients. A really big impact is when you're testing patients who aren't presenting with any symptoms. You're going to take that patient from high pathology with no symptoms, from the prophy exam, fluoride, see you later, see you in 6 months. Prophy exam, fluoride, see you later, see you in 6 months. And in the meantime, those pathogens are festering, and maybe later he'll get symptoms, or maybe he has halitosis. Maybe he has insulin resistance. Maybe he has some cardiovascular stuff going on. Maybe he has some other things over here that we know that high pathogen might also be driving some inflammatory issues in the body. So where your biggest impact is going to be finding your high pathology, no symptom patient, doing your testing. Maybe you're going to do a prophy. Maybe you're going to do a laser decontamination, some ozone. Maybe you're going to do something like perioprotectase for that patient. So that's where your ROI is going to increase because your previous healthy patient is actually not really healthy microbially. And then you'll put them on a 3-month recare. Hopefully you're going to test them again. And that patient, you're going to walk through and you're going to work on getting healthy according to the testing process, not how he's presenting clinically. Maybe it's going to involve a referral office. So that's where your biggest ROI is going to be in your office. And this is kind of like my explanation of the current preventative model. So right now, what we do is if someone has no bleeding, healthy tissues, we're doing that 1110, right? But I'm going to challenge you. There's a lot of healthy patients that microbially are not healthy and they have perio problems. Gingivitis, right now, you have to have 30% bleeding. One third of the mouth has to be bleeding before we can use a 4346 code, which is crazy. And there can't be any bone loss. So, and I headed up a perio protocol, and we had a lot of kickback with hygienists who the The process for our 43-46 was we're going to do a 43-46. I'll see you in 4 to 6 weeks. And we're going to evaluate and we're going to see if you have bleeding again. If you have bleeding, you're not healthy. We're going to do another 43-46. And that's how you're supposed to use it, you guys. It's it's a scaling with the presence of inflammation. It's a 4-3 code. It's a period code. It's a therapy. Use it as a therapy. A 1110 is just a prevention code. So that's super important. Period infection, we all know how to use that code, but it's still working on probing depths and gingivitis and things like that. So we're looking at disease presence. And same thing with cavities. So we have the chance to use the testing to be more preventive because we're not looking for disease presence in the mouth before we're actually starting to do true treatments. And like I said, it's going to focus on the disease pathology and the imbalances that are causing those dysbiosis problems. And it's going to lead to better referral processes. Whether you're looking at airway, whether you need someone to do a sleep study, whether it's medications or mental health and stress, you'll have a better understanding of where their inflammatory issues are coming from. Okay, we'll cover some super interesting cases. Now, this case we do have in our provider platform, and I did briefly cover this in the last one, but this is a really good reminder of those tough cases. You can have your perio patients who have seen specialists year after year, and maybe they've done, some past testing, and it really wasn't super conclusive, but they're still struggling with 50% bone loss, lots of inflammation. This patient was dealing with 50% bone loss, was complaining of abscessing, and was doing everything he was supposed to. And even in our test, it looked a little, everything looked okay. But the advantage of doing the raw results gave us some really good insights. So we found out this patient had 78% of his oral microbiome was taken up by Serratia marsans. And then just look at the other things, like Klebsiella is another Enterobacter family, which is opportunistic in nature. And then there's another Serratia and another Serratia and another Serratia. So he had a huge opportunistic bacterial infection that was wreaking havoc in his oral microbiome. And really, only the Bristle test is testing for these bacteria and gave him some answers. So once we figured that out, we put him on some protocols. It didn't really work. We did some testing and we were still having trouble. So we did a little bit more research, which is what I love about what I do. I love diving into the tests. David Lynn, our scientist, realized that Serratia marsans was susceptible to xylitol. So after we put him on xylitol 3 times a day and Lactobacillus rudii, we were able to significantly reduce the abscessing and recover his inflammatory issue and his perio problems. And he had a lot less plaque biofilm as well. So that was the driver for his plaque biofilm and staining and tartar buildup. So we made a significant improvement in this person because we were able to test for bacteria that until I read this case study and presented it, I had no idea what Serratia marsans was. And now I do all the time because actually it's not that uncommon. We have quite a few individuals, and including one of my own, who I treated with ozone, and she had ended up having Serratia as a significant bacteria in her oral microbiome. And it's one that I see at high numbers when it is out of control. So it really can give you high clues on what the driver is with our testing. This is another really interesting case. So if you have your patients who are suffering with acid erosion issues. So I just had this really cool call about 2 weeks ago with a doctor. I work with doctors closely. I go over the test results and then we kind of look at things, and I like to pick things apart. So I was like, let me pick this one apart for you. So this patient is in his 30s and she's super concerned because he's got acid reflux. He has diabetes 1.5, which is a little bit unique, but he's losing teeth structure. So she said in the last 6 months, he has lost, a whole cusp off one of his premolars. So she's like, I don't know what to do. He has got GERD, acid reflux. We know that that's a problem, right? So where does the bacteria come in play with that? So I found a really cool study on the oral pharyngeal microbial flora with acid reflux. And the presence of bacterial flora found in the posterior pharyngeal wall was increased, and the predominant organism in the study was an Enterobacter group. So this was the chart that I found in the study with the Enterobacter. So E. coli, Klebsiella, Campylobacter, and Enterobacter were the four main enterocases grouping and that we found in that laryngeal. But look at his test results. So we have Enterobacter chlorei, Klebsiella oxyntella, Serratia, another Enterobacter, and then Klebsiella pneumoniae. Klebsiella pneumoniae, once again, in that raw results I found was at 35.6%. That's way out of whack. So he is, kind of representative of that case study or research paper that I found. So we know that the bacteria in his mouth is also tied to his acid reflux issue as well, right? And we know that the acid reflux makes it a perfect environment for pathology that causes decay issues. And this was his decay score. He has an exuberant amount of decay. This was the same score that I showed earlier. So severe Candida albicans and strep mutans is present, and we have all kinds of lactobacillus issues. So he's super high risk for caries issues as well. So pH from the acid reflux is now making a really key great environment for the pathology that can cause decay issues. So we need to get his biome under control, his pH under control, because it's driving issues with demineralization. And how does the gut play in it? So his gut score was pretty significantly high too. Once again, Klebsiella, Enterobacter, Fusobacterium are tied to that gut impact score. Now, I'm going to remind you that gut impact is, causative of leaky gut issues, and obviously he has acid reflux. He's got some gut problems. Klebsiella pneumoniae is a significant impact on that gut health issue. So we need to address his gut. So we talked about doing a referral for a functional doctor to try to get his gut issues under control, or we're not going to get his teeth issues under control. And then let's just talk about diabetes and gut health. So I found a really cool study that talked about gut health and how with latent autoimmune diabetes in adults, which is that diabetes 1.5. And what that is your pancreas starts to deteriorate. So you eventually do end up on insulin. So it's kind of in between type 2 and type 1, where you slide into type 1, where you become insulin dependent. But look at the bacterial component again. I'm seeing that Enterobacter again coming up. So we know that the bacteria in his mouth is also tied to how progressive his autoimmune disorder is going to be. And I took the Terry Walls test, or the Terry Walls course, and she talked a lot about Klebsiella and autoimmunity. So latent autoimmune diabetes in adults, I would say probably has some, tied to that Klebsiella and Enterobacter overgrowth. So getting that under control in his mouth is going to help his outcomes of his diabetes progression with his autoimmune disorder. And I dug in a little bit further. Klebsiella pneumonia loves a glucose high environment. So it's so high because the diabetic person is the perfect host for Klebsiella pneumonia. It lives off of glucose. So how do we deal with Klebsiella and Enterobacter and those types of bacteria? Xylitol. It loves glucose. So it's one of those bacteria that will take in xylitol but can't thrive off it, and it causes it to die off. Serratia, same thing. It's in that Enterobacter family. So we can put this patient on xylitol and help cater the pH of his mouth, which is going to be a benefit, but it's also going to be antimicrobial and actionable against a bacteria that we know is possibly driving some of his acid reflux issues and also is tied to his autoimmunity. Super cool. So she was going to do some stuff in office, and her and I worked on a treatment care process. So I always tell patients to disclose electric toothbrush is a must, brush, floss, tongue scrape. Of course, I love an ozone water flosser. There is a new one on the market by Biojet. I love to recommend. If you can't do ozone, then hydrogen peroxide is great. Once again, ozone or hydrogen peroxide, great against those anaerobic bacteria. Colloidal silver and aloe, we put that in because his candida overgrowth was exponential. And then because he's losing his enamel, the Feed Your Good Guys varnish is going to be recommended to place after. I put that after because we need that arginine and xylitol and hydroxyapatite in the mouth, for remineralization. So, and then we put him on a more maintenance type of schedule after the 2 weeks for another 12 weeks using Elementa, which is high xylitol, which is going to help with that Klebsiella, the pH balance, and the Enterobacter overgrowth along with remineralization. And then, of course, supplements. We do arginine, nitrate, xylitol. I always recommend checking vitamin D and K2, making sure our levels are at 70 or above, and omega-3s are super important as well. So we're going to weed, feed, and seed the oral environment alongside the practitioner as she's treating in office. But he's getting acid reflux issues, so this is going to be super key. And then, like I said, a good referral to a gut specialist is going to help. Here's another case that I'm working on with another practice. We're kind of in the working of this, but unknown ulcers. This is a individual who has a history of cold sores. So we know she's got herpes simplex as a child, history of canker sores as well. She does take Abrevia when she gets her cold sores. We don't currently have any diagnosis of any autoimmunity. She does take lysine and has done some probiotics stuff, but she's got these sores that they're atypical. They're not normal canker sores. If you can see, they're in between the papilla, they're on the palate, they're in the back of the pharyngeal area on attached tissue. They're kind of everywhere and they're really sore. She breaks out with these and it takes her a couple weeks to heal, and then they're coming back. She's working on gut health. So they did a really great baseline test, once again, testing when she didn't have a breakout, and she actually looked pretty good. She is working on her gut health, so she does show some gut problems there. But then in the second test, she looks pretty okay, but what jumped out with me was all of a sudden our beneficial bacteria have taken a super dive. So that tells me there's got to be something opportunistic kind of jumping in, and the gut score is kind of similar. So I went into the raw results, and the new test showed Enterobacter at 23.49%. So oral sores and ulcers can be multiple factors, the viral. So I kind of was like, ooh, the herpes, you could maybe do a longer treatment for herpes. We do show herpes simplex in our tests, and she didn't show it in her salivary test. So I'm not really suspicious of it being a herpes issue. But the bacterial overgrowth at 23% from not being in her test at all kind of indicates I'm waiting on a third test to confirm that it might be this Enterobacter. So we talked about, possible antibiotic treatment for Enterobacter. I found a really cool study with Enterobacter and one other bacteria causing flesh-eating disease, which it's obviously not what it is, but obviously Enterobacter can cause some sores in the mouth. It's opportunistic in nature. Once again, it's in that Enterobacter family. So we talked about doing hydrogen peroxide. I'm going to do dentocidin. She wanted to be more on the holistic side of things. Dentocidin has garlic and different botanicals that can help break up biofilms. And then I'm going to put her on xylitol because of the Enterobacter and knowing the Enterobacter is in that xylitol susceptible family. And then we're going to kind of go from there. So I'm waiting for her third test to see where the outbreak is and where that enterobacter is coming in. So I'm suspecting that to be the main pathogen that we're dealing with that's causing some of those. And actually, she's not the first. I have another patient who had a COVID outbreak and her mouth looked very similar with those sores. So watch that. And so if you have those types of patients, if you can test, if you have your baseline test, then you'll be able to identify what's out of balance when you do have an outbreak. So let's talk about prevention. And I'm gonna just list a bunch of little quotes that I get on a daily basis because we market to halitosis patients a lot. So our tests are available to the general public. They can order the test, and we get a lot of halitosis patients. So these are some quotes that I've had from halitosis patients. I go to the dentist and all of these other doctors, and they can't figure out why I have bad breath. No one has answers for me. I have seen a gastroenterologist. I've done a scope, and they don't see anything there. I have people who have removed their tonsils, you guys, like because their halitosis is so bad. They've gone through the painful process of adult removal of tonsils to try to deal with it, and they still don't get resolved from bad breath issues. I had bad breath since puberty, and I'm in my 60s. I had one of those calls today. I've lost my job. I've lost friendships because of halitosis issues. Listen to your patients with halitosis, you guys. They don't talk to you a lot. I hear it all the time because it's private, but your patients are suffering. And halitosis is a pretty significant sign that there's either gut, nasal, or oral issues that need to be dealt with microbially. So if your patient comes to you and you're testing, do a test and figure out what's going on. So his main concern was he's had chronic halitosis since puberty. He's using a manual toothbrush, fluoride toothpaste. He doesn't really floss. He's tongue scraping. He might use a breath spray and some gum, and he's using Scope. Let's look at his test results. So beneficial bacteria are super low. His gum inflammation score is out of control. So is his tooth decay score. His halitosis score is exuberantly high. His gut impact score is high. His nitric oxide score is average, and it's actually working onto the lower side. That kind of correlates sometimes with the halitosis score. And his diversity is really high. When diversity is in the red like that, there's too much going on in there. Well, we need to bring it back into balance. Bacteria in the beneficial category, we want it high because the beneficial bacteria help to keep things in check. So we don't want to use strong antimicrobials all the time because our beneficial bacteria get wiped out. I see it all the time with Listerine, TheraBreath, and honestly, strong antimicrobials with essential oils and things like that. Like even if you're on the holistic side of things, I work for a company. We do oil pulling. We have essential oils. I love essential oils for phase one, just for a short bit of time. It's great against perio-pathogens and things like that. But even oregano, tea tree, fennel, all of those are strong antimicrobials that will have a beneficial, or an impact on your beneficial bacteria. His gum inflammation score, all the red and orange complex bacteria are present pretty much. That's what this looks like. So he's pretty significantly high risk for periodontal disease. And then here are the systemic connections as well. So we give a little score as well for how it's also tied to systemic health. And he's high on a lot of these pathogens. Tooth decay, once again, it's that Prevotella denticola in his score that's driving that. So it's anaerobic in nature, so we'll work on getting that low when we start treating him. His gut impact score, significantly high. Little hint, Campylobacter, usually probiotics are beneficial to help bring those down. And then zinc is helpful as well. So helping Campylobacter with zinc lozenges would be beneficial. But once again, his chief concern is I have halitosis issues. So his halitosis is gum liner in nature. So we'll give you different categories with the halitosis scores. Sometimes it's opportunistic, sometimes it's tongue coating, and sometimes it's gum liner. So his are more gum lining in nature. So he's high risk for perio. And these are all the bacteria involved in his halitosis score. So we'll start working on this. So when I look at the test results, I'm like, okay, what's our chief concern? I hone in on that component, knowing that when I start addressing those, everything else is going to kind of come into balance. His nitric oxide score, like I said, is on the medium side as well. So this person is clinically asymptomatic, you guys. He's a college student. He's on Prozac. He suffers from anxiety, so he has dry mouth. He has no signs of gingivitis and perio. He sees a dentist every 6 months. He doesn't have current decay issues. And he's been to the dentist several times and everything looks fine. I don't have any answers for your bad breath. But he's the one who is going to be severely impacted. So this is the care plan I put him on. We're going to do a disclosing process. I told him not to use sodium lauryl sulfate, put him on a hydroxyapatite toothpaste. I recommended ozone or hydrogen peroxide. We're going to do smart mouth just for the purposes of that's a strong antimicrobial and affordable for him as a college student. We're going to do the supplements, arginine, nitrate, and xylitol to help cater the environment to grow the beneficial. Our supplements, I think of them as compost for the soil. So we're growing an environment that we need to shift the environment that made it conducive for those bad bacteria in the first place. So arginine, xylitol, nitrates help feed the good bacteria, so do oral probiotics. The second phase, we're going to do a xylitol-based rinse and try to keep that pH balance healthy, and then add that hydroxyapatite in, and then Boca tablets. You guys, I have been struggling with certain bacteria, and I'm getting really good results with the Boca tablets. So we don't have any affiliation with Boca, but there's a few bacteria that I have been struggling with halitosis problems, and I finally found a product that I think is working for that bacteria. So I'm putting him on Boca because his main issue has been halitosis, and I'm getting really good results with the Boca tablet rinses with that. So this is the perfect example of this model. Going back to the biggest influence on ROI, he is your patient who is coming to you and saying, I have halitosis and you're not seeing anything in my mouth and I know something's wrong, and microbially he's a nightmare, right? So it took the test to show that he is severe risk for perio, severe risk for caries issues. He's got possible gut problems, and he would benefit from going back to his dental practice and saying, hey, can you do a laser decontamination, or maybe could you get me some PerioProtect trays? Put him on a more frequent recall. It makes a huge difference. And then retest him. All right, I'm going to let you guys unmute. And if you have any more questions, you can go ahead and shoot some questions out. So go for it.
So I did have a question, actually. It was back when you were talking about nitric oxide, and you'd had three things that you'd mentioned. And did you say urinary tract health is related to nitric oxide?
So insulin
Yeah.
resistance, so nitric oxide is blood pressure,
Yeah.
immune health,
Yeah.
and insulin resistance. And there's other things I'm sure that it's involved with, but those are the big three that I have found research on where nitric oxide is super important.
Great. Insulin resistance. Thank you very much.
Yeah.
Great presentation. I appreciate it.
Thank you, Sally. Anybody else? Feel free to unmute and ask.
We did get a written question. It's from Sarah, and she asked, would you use PerioProtect to help with caries risk?
I absolutely would. So hydrogen peroxide is great against Candida albicans. And then most of your caries pathogens are anaerobic in nature. So your patients who are high caries risk, I love ozone trays, and I do think that the Perio Protect trays would be beneficial.
Yeah, well, thank you so much, Heather. Wonderful presentation. And thank you so much to everyone for attending. We really appreciated your participation, the great questions and dialogue we saw in the chat. As a reminder, if you're interested in learning more about Bristle, you can find us at bristlehealth.com/providers. And that's where you'll find everything related to how we're working dental practices. We'll be following up as well, and be sure to take up the opportunity to learn more about Bristle testing, book a training with Heather where you can get even more personalized and one-on-one training, and let us know if there's any other way we can help. But thank you all so much again, and have a great rest of your evening.
Thank you, everyone.